Keep me on track, please. So diabetes is a massive topic, and obviously we sort of think about diabetes in dogs and cats as quite different diseases. Why? What's the difference between dogs and cats?
The type of diabetes that they tend to get.
Good.
So,
why?
Dogs tend to get type 1, which is more believed to be like an autoimmune destruction of the islets of the pancreas.
Good.
Whereas cats tend to get type 2, so more kind of a relative insulin deficiency, due to like things like obesity or and less likely to get things like pancreatic destruction. They still do get that.
Good.
Like pancreatitis and stuff.
Yeah, absolutely. So what proportion of the pancreas is made up of islet cells versus non-endocrine pancreatic cells?
Not a lot.
Not a lot. 25%. So it's a really small amount of the pancreas is endocrine. So there's plenty of reserve in normal patients for insulin production, but you've got to get pretty significant pancreatic destruction to lose that endocrine function of the pancreas. So Josh mentioned insulin resistance, sort of, as opposed to insulin deficiency in dogs and cats, and type 1 versus type 2. Does anybody know what causes that in cats? What causes this is a really big question to ask people just over video like this, but etiopathogenesis of insulin dependence in cats. Can anyone answer that? Like, why can't we just reverse the insulin resistance? Do they still have functional islet cells that will produce insulin?
I think it's because it's not just the obesity. So when they're obese, they're insulin resistant because they get the adiponectin or something released as well. It causes insulin resistance in cats. But not every obese cat is diabetic because they also have to have some sort of islet destruction going on because they produce stuff because they're then chronically overproducing insulin. That becomes damaging to the pancreatic islets.
Good. Yeah, exactly. So they get exhaustion.
Yeah, so they get exhausted. And then chronic overstimulation of insulin does cause, like Josh said, they're not just insulin resistant, they also get pancreatic islet cell death from.
They do, exactly. Yeah, exactly. So they get a lot more insulin resistance peripherally. So if you've got half of the amount of insulin receptors, then you've got to produce double the amount of insulin to have the same effect. So the pancreatic cells, the islet cells get exhausted, the beta cells, we should be specific about the cell type. Beta cells get exhausted. There's a really interesting study that looks at what contributes to that. And they did it in sort of lab cats, iatrogenic hyperglycemia over the course of 10 days resulted in 50% less beta cells.
Wow.
So there's this concept of glucotoxicity. So prolonged hyperglycemia is actually toxic to beta cells. And so where you'd think beta cells should be hypertrophying in this situation where you need more insulin, they're actually dying.
Is that the glucose itself doing that, or the effect of the glucose, like causing the cells to have to produce other compounds and things?
Such a good question.
Or maybe no one knows.
Where did I write this down? I don't know actually, but we can talk about, oh, do I know? Okay, no, I don't know. Sorry.
Maybe no one knows.
So there's this, I've sort of got this little list in my head, and I've lost, when you're doing fellowships, all of the details, and I've still got the list in my head, but the why is gone. So beta cell loss or beta cell dysfunction in cats with diabetes, we've got exhaustion, beta cell exhaustion, loss of numbers of beta cells associated with glucotoxicity, and also lipotoxicity. So what happens when we've got insulin deficiency at a muscle cell, at a fat cell level? What will happen? So the body needs glucose. It's not getting, the cells are saying, I'm not getting enough glucose.
Do you mean like the counter-regulatory hormone activation?
No, sort of more, how's it, not hormonally, but how's the body going to get energy? What's it going to use for energy instead of glucose?
Oh, right. So like breaking down fat, basically. So releasing like triglycerides and going through basically to produce ketones.
Yes.
Yeah.
Exactly, as a source of energy. Beautiful. So fat is going to be broken down. We're going to get increased triglycerides in circulation, and that's going to be toxic to our beta cells as well. So we've got glucotoxicity, lipotoxicity, and then in cats, cats and humans, this is where they're kind of common, get this, in fact, all animals get amylin secreted with their insulin from beta cells. Cats and humans, amylin forms amyloid, whereas in dogs it doesn't. So if you did histo on a diabetic cat's pancreas, you'd have amyloid deposition and replacement of those beta cells with amyloid, fibrosis of the pancreas or the islets, whereas in dogs, you don't get that. So that's another sort of way that we get sort of more permanent loss of islet cell function in cats, as opposed to dogs, where, as Josh said, is mostly immune mediated. We got pretty deep pretty fast. Sorry about that. Let's go back to the causes of diabetes. We've said immune mediated. What else might cause diabetes?
Severe pancreatitis, destruction.
Excellent. Yeah.
Insulin resistance, or like causes of insulin resistance chronically.
Yeah. What might they include?
So it can be any kind of peripheral inflammation, infection. So big ones there are like urinary tract infections. Really big one.
Yeah.
Can be cancers as well. Pregnancy, impact females as well. Progesterone.
Good.
Obesity.
Yeah. Excellent.
Acromegaly.
Acromegaly, very good. Yeah.
And all the other endocrine diseases as well. So like hyperadrenocorticism in dogs, hypothyroidism.
Yeah.
As well. And
Hypothyroidism?
I think so.
This is causes hyperlipidemia. So in theory, yes. I think the link might be the endocrine autoimmunity there in dogs, hypothyroidism and pancreas.
Oh, yeah, okay.
But I'm not sure hypothyroidism causes diabetes. Yeah. There's one more. You've mentioned hyper A. One more iatrogenic one.
Sorry.
Yeah, exactly. So excess glucocorticoids exogenously as well. It's a really obvious one. If you're in clinic, you'd get that, but if you're in exam, you've got to put it down as well. Excellent. So you got all of them. What about, there's one more. Oh no, there's not. Don't worry about it. So let's talk about physiology a little bit. When we have a meal, what are the beta cells' response to that meal? What happens with the blood glucose and what happens with the insulin levels at what phases?
Well, as the blood glucose goes up, the insulin level goes up.
Perfect. Yep. Do you know over what duration or how long insulin acts for?
No.
No.
But you let the young ones answer that.
Does anyone know?
I assume probably around 12 hours or so, but isn't it kind of released quite smoothly compared to the way we would give it?
Good. Yeah, exactly.
I'll explain that.
Yeah. So duration of action is pretty short, actually. So when you first eat a meal, the very first molecules of glucose that are absorbed go to the beta cells and stimulate insulin production, and we get this first phase secretion of insulin secretion that lasts at first. It's the first 10 minutes, I think. Yes, peaks at 10 minutes. And then we get a second phase of insulin secretion. So as we've absorbed all the simple carbohydrates, and then the guts are just breaking down all of the more complex carbohydrates and absorbing them a little bit more slowly. So then we get a second phase of insulin secretion, which peaks over 3 hours or so after the meal. So first phase, 10 minutes, and then another phase at 3 hours after the meal. When insulin is secreted, where does it go?
Into the bloodstream initially.
Which circulation?
Oh, yes. I'm not sure that it's portal.
It is.
It is.
It is, yeah. And I think the only reason I sort of flag this is because insulin hits the liver first when it's produced endogenously, whereas when we're supplementing it, it hits systemic circulation first. So the liver never gets the same concentrations as insulin when we're supplementing as it would if it was produced endogenously. Just good for when you're kind of, I guess, conceptualizing why a patient with diabetes might still have some liver enzyme elevations or hyperlipidemias and things, because that will, the insulin will have impacted fat metabolism in the liver. And then what impact does insulin have once it's gone, or what impact does insulin have in the liver?
So that'll it'll cause storage. I'm just can't remember if it's glycogen or fat. I think it'd be glycogen initially, wouldn't it?
Yeah, perfect. So it will decrease fat breakdown because we don't need fat for energy because we've got glucose, right?
Mm.
And it will decrease gluconeogenesis. So we don't need to produce more glucose. We've got glucose coming in, and it will start storage of glucose. Good. What about when it hits peripheral circulation? Where does insulin act in the body?
Well, pretty well everywhere, doesn't it? Anywhere that needs energy, muscles, but also fat.
Good, yeah. Muscles and fat cells predominantly. There's lots of different glucose receptors or glucose transporters that allow glucose to get into cells. And the ones that are insulin receptive are GLUT4, GLUT4. And they're found on muscles and fat cells predominantly. So if we've got insulin hitting those muscles and fat cells, what's the insulin allowing at those GLUT4 receptors?
A breakdown of glycogen and fat to glucose.
Well, we've got
wait a minute, that can't be right.
Yeah, we've got the glucose, we've got the insulin. What's the insulin facilitating at us? So we've got the glucose in circulation now, and we've got the insulin in circulation, and they both hit a fat cell. What's going to happen?
It'd be fat storage.
Yeah. So what the insulin actually does, it's like a key which opens that GLUT4 receptor and allows glucose to go into the cell. So we're storing fat. We're definitely not in a catabolic state. We're in an anabolic state. But we're not just storing fat. We're actually building glucose energy, so glycogen within the cells. So muscles and fat the GLUT4 transporter will open in response to insulin, and the glucose can just flow into those cells. So it facilitates movement of the glucose out of the bloodstream into the cells, and then the cells can store it up to use later. Make sense?
Mm-hmm.
Good. So if we then look at what causes, when we've got insulin deficiency, what are some of the clinical signs we might see?
Like polyuria, polydipsia.
Good. Why?
Because the kidneys at a certain saturation point lose their ability to reabsorb glucose. So you get lots of glucose with osmotic force pulling it into urine.
Mm-hmm.
You wee a lot, and then you need to drink a lot to keep hydrated.
Yeah, good. So it's a primary polyuria with a responsive polydipsia, reactive polydipsia. What is that saturation point? What does the blood glucose need to get to before we'll see it leaking out in the kidneys?
I think it's like 11, 12, or 13 millimole per litre. Sorry,
in dogs, yeah, that's correct. 10 to 12, they say. What about cats?
It's not the same.
It's a little bit higher, but it's actually really variable between individuals. So you can have a cat with a glucose of 20 and no glucosuria. The cats just don't follow the rules. Okay, so PUPD, one of the symptoms. What are others?
Weight loss.
Yeah. How come we've got weight loss?
Sorry, I'm next to a road, so I'm sorry if you can hear it.
Yeah.
Because over time they'll go into a state of ketosis from mobilizing their fat for energy sources because they're unable to mobilize that glucose.
Good. Yeah. Excellent. Does everybody understand that?
Yeah. Basically starving.
Exactly. Yeah. So the other thing that also, go ahead, Jeff.
Oh, they're going to be polyphagic as well.
Good. Yeah. Exactly.
And then when they become sick diabetics and they stop eating, they'll get ketoacidosis and dehydration.
Yeah. Now I just want to check this. So what happens? So you mentioned they're polyphagic, and they're basically starving, so it sort of makes sense. Which part of the brain triggers hunger?
Is it in the hypothalamus?
I don't know actually where it is. Sorry.
Oh.
It's in that region.
The satiety center.
Good. Yes, got it. Satiety center. Is that how you say it? Satiety?
I don't know.
No, I say it.
Okay. So all these words that I've only ever read and never actually heard said. I say satiety center in the brain. So when the satiety center doesn't have insulin, the glucose in circulation can't get into the satiety center, and the satiety center says we're starving, we don't have enough glucose, and triggers hunger. That's a mechanism of polyphagia. And then what other symptoms do we have? We've pretty much covered most of them.
You might, if it's
muscular weakness.
Yes, good. Is that what you were going to say, Helen?
I was actually going to say dogs coming in with cataracts.
Oh, that's a good one. Yeah,
it is a good one. Yes, very good.
Don't notice the preceding signs.
Yeah. So let's put cataracts. That's a really good presenting sign. Let's put that in the complications section, and we'll talk about what the complications of prolonged hypoglycemia are. So muscle weakness. Why would we have muscle weakness?
Because there's a lack of glucose and energy at the cellular level.
Excellent. Yeah. So we might get muscle weakness, lethargy, decreased exercise tolerance, all of those things. Okay.
Anna,
Yeah.
in cats being down in the hind, is that muscle weakness or a peripheral neuropathy?
Combination.
Okay.
But good. So let's then, I've sort of in my mind, again, I've got these lists in my mind. So I've got sort of the symptoms of diabetes, and then I've got the complications of prolonged hypoglycemia, and technically they're kind of overlapping, aren't they? So let's talk about cataracts. What causes cataracts in long-term hypoglycemia?
I think it's edema of the lens because glucose enters the lens and osmotically encourages water to enter.
Good, yeah. So glucose enters and then is reduced to sorbitol, and it's actually sorbitol that accumulates in the lens. And you know, the lens is these like really parallel fibers. So when you get edema and they start to get all wiggly, you can't see through them as well. It's like a polarized lens kind of thing. And they start to get opacified in there. Is there any other ocular complications of prolonged hypoglycemia?
Retinal degeneration, I think, isn't it?
Good. Very good. Yeah, it's a diabetic retinopathy, which is often associated with microhemorrhages and aneurysmal dilations of the blood vessels in the retina. But it's very important that opthos, when they're looking at doing cataract surgery, they always do an
Electroretinogram.
ERG, that's what it is. Thank you. ERG, to make sure that the signals are getting through to the brain from the retina, so the retina is functional before they do the cataract surgery. There's no point doing the cataract surgery to restore vision if you just need to do an enucleation for the symptoms of the cataract. If they're never going to get sight back, there's no point doing the phaco. Excellent. What other complications? Neuropathy, Sam said, the peripheral neuropathy. This was a fellowship question for me. What is the cause of peripheral neuropathy in diabetes? Anyone?
It's a good question.
And the annoying thing is nobody knows.
Oh,
Is that what you're at then? Just don't know.
I skipped it. I just skipped the whole question. I was like, I don't know. It was the wrong approach. Don't ever do that. But it was quite nice. I came out of the exam and spoke to Georgina Child. I was like, oh, I got this terrible question. And she's like, that's bullshit. Blah, blah, blah. I should never have asked that. It's so controversial. There's a lot of different theories about why it happens. What are they? So when you've got the inability, when you've got excess glucose, you end up with excess sorbitol. And the process of converting glucose to sorbitol uses up an energy provider, NADPH. Do you remember that one from biochem?
Yeah.
Now, when you're using up your NADPH to convert your glucose to sorbitol, because you've saturated all your other mechanisms of processing glucose, you are taking away the capacity to make glutathione. Do you remember from our liver discussion what glutathione does, what its role is?
Antioxidant.
Good, excellent. So if you've got decreased capacity to create an antioxidant, what are you going to get?
Oxidative damage.
Oxidative damage, exactly. Yeah. So that's the most kind of current working theory of why we get peripheral neuropathy and nephropathy as well.
Is that damage irreversible, Anna?
No, it is reversible, but you need really, really, really tight glycemic control. And it takes months because nerves just take so long to heal.
Okay.
As long as the basement membrane remains intact, nerve sheath remains intact, they can regenerate the nerve. Okay. But they just grow like a centimeter a month kind of thing. It's a really, really slow. again, there's lots of theories, so I don't want you to sort of say, Anna told me that this is the only reason why we get diabetic neuropathy, but that's the most sort of current working theory. How would we diagnose peripheral neuropathy? What do they look like?
You probably have conscious proprioceptive deficits and scuffed toenails. You may also have weakness, but I guess you'd be looking at and also spinal reflexes. You might have you'd have lower motor neuron reflexes. Should help you differentiate it from the myopathy.
What's their gait like?
Cats get like a plantigrade gait, so they walk on their hocks.
Yes, good. Yeah, I think that's the most. I think when I see a diabetic cat and it's walking pretty normally in a consult room, I always ask the clients what the strength is like, jumping on and off the bed, on and off the bench and stuff, because that Achilles strength, that spring, is kind of seems to be the first thing. It's the longest nerve. It's the first to get damaged. That sciatic. When it's quite progressed, we get a plantigrade stance, but I quite often am looking for subtle findings that we might be dealing with a bit of a neuropathy based on strengths and things. How would we diagnose that definitively, that we've got a peripheral neuropathy?
I can't remember the name for it. Electrical nerve conduction studies.
Yes, good. EMG, good. You gave me ERG before, Jeff, so you can have the EMG.
Well, my initials are GG, so I've got a few around. GG's around.
Yeah. So the muscle one. So you essentially stimulate the nerve and then measure how long until the muscle fires. So you can detect the electrical signals running through the nerve, the speed that they're running, and comparing that to normals. What is the probably most common complication we see of diabetes?
Diabetic ketoacidosis.
Good, yeah, excellent. What causes that?
It's basically when the diabetes is not controlled and you have hyperglycemia, increased production of, or increased fat breakdown and ketone production that become acidotic because of the ketones.
Excellent. And how do ketones make them sick?
They're acidic, so they basically make them the acidotic. The buffer runs out.
Yeah. And what symptoms would you typically see a diabetic ketoacidotic patient present with?
Profound dehydration, usually, because they're just losing so much in their urine. They're usually vomiting as well.
It might be tachypneic if they're really acidotic.
Yeah, good. And so why are some patients, the clients come in and they say, oh, they've been drinking more for 6 months and they're still walking around, they're still eating really well, and then others come in crashing with diabetic ketoacidosis? What's the difference?
Could it be how relative the insulin deficiency is? Like if it's like a total insulin deficiency versus some peripheral resistance?
It's a good point, and your answer is completely correct, but simplifying it a little bit, diabetic ketoacidosis always have a comorbidity. So a well diabetic will never go into diabetic ketoacidosis. They always have something else going on, a UTI, pancreatitis, pneumonia, something like that tips them into a crisis. So we always look for the comorbidity when we diagnose diabetes, DKA. And it's that illness and insulin resistance that is what sort of creates the imbalance that they then can't, then they spiral out of control. We could talk about DKA on its own for a whole session. How deep do we want to go?
Can we do a session on it
Yes.
separately?
Can we do that instead of pyometra?
Yeah.
Yeah.
Cut it out.
Yes. So we'll do it like pyometra as a trigger for DKA. So we'll cover like a
Oh, I love it.
Okay, good. Done. So I'm going to stop with and not go any deeper into DKA there. I think, well, okay, let's go into treatment and let's talk about dogs first. How are we going to manage a well diabetic who's newly diagnosed? We don't need to talk about diagnosis, do we?
Well, it's important to get blood glucose, blood sugar and urine sugar because particularly if it's a Basenji, it might be
good. Yeah.
It might be it might be glucose in the urine.
Yeah. Yeah, Fanconi. Yeah, that's a mean trick. Then I don't start insulin based on glucose in the urine alone.
Or one blood sample on a stressed cat.
Ooh.
Or a cat that's just been hit by a car.
Yeah.
In its head.
Yeah, that's a really good point. What's the cutoff? What's the highest blood glucose you would expect in a cat that was induced by stress?
Well, I think it can be really high, like high 20s.
Yeah. Documented as high as 36.
Yeah.
Yeah. So in cats that are really, really unwell or hit by car, as you say, trauma, really stressed. So you can't differentiate stress-induced hypoglycemia versus true diabetes in cats based on blood glucose alone. How would you overcome that? What test would you run if you think?
You could run a fructosamine.
Good. What will that tell you?
It's the glycosylated proteins, mainly albumin. So you can use it as long as your albumin is not affected by other things. And it tells you the glucose concentration over the preceding 1 to 2 weeks in cats.
Good. Excellent. Yeah. So that's exactly what I do. If I had a question, there was sort of questionable clinical signs, maybe attributed to diabetes, but they also came in with pancreatitis, then I'd run a fructosamine for sure. Okay, treatment. Let's go dogs first because we're going to talk about these quite separately. How do you treat dogs, newly diagnosed well dogs with diabetes?
Well, with insulin, can insulin usually.
Yeah.
The blood glucose curves are very popular, but they can be unreliable because they're done in hospital and not at home. And also they vary from day to day. There's a large degree of normal variation, as I understand it.
Good.
So, but assessing it at home, well, the owners can learn to prick the ear and just get a drop. The modern glucose assays will only need a tiny drop.
Yeah.
The little handheld machines. The other thing I used to do is tell people to train their dogs to get a short urine sample. Like first thing in the morning, take it out for a wee so that it eliminates its average urine sugar over the night. And then an hour or so later, take it out again so you get a better picture of what's spilling over.
Oh, that's a good idea.
But I mean, if there's any there at all it tells you is it's above 13 or whatever, 12, or it doesn't tell you how far above.
No, exactly. Yeah.
But it'll pick up, be more sensitive for a hypoglycemic situation.
Well, sort of, but you wouldn't drop the insulin dose based on a negative blood urine glucose, would you?
No.
It would still be 10.
It'd just be an alarm bell to
do a curve. What about glucose sensors? Is anybody using them?
Yeah, that's all we use now.
Yeah.
Interstitial.
Yeah. glucose monitors. I think it's important to note that the monitors are fantastic within the ranges that humans normally see glucose. So sort of 3 to 15-ish. But because we've quite often got patients going up into the 20s and things like that, sometimes at those extremes, very low, very high, there's not that great correlation between a biochemically kind of run blood glucose and the interstitial blood glucose. But I think the sensors give us a really good indication of whether we need to up the dose or lower the dose.
They're better at picking up the Somogyi overswings overnight too, as I understand it.
Very, very much so. But I think, so what, how am I going to word this? So if you've got a patient that over the course of the day over the course of 24 hours, spends about half their time over 15, what's going to be happening to their glycogen stores in their liver and muscles and things?
They'll get used up.
They'll get used up, exactly. So we sort of think we're sort of providing safety by running them a little bit high because we're scared of hypos, but actually all of their stores are being used up. What happens if you do give them a little, like the insulin dose is a little bit too high? What happens to the blood glucose?
Well, it'll drop, but you might get the counter-regulatory hormones kicking in and stopping it bottoming out.
Good, yeah. And in the vast majority of normal patients, if you now that we've got these really nice curves, that hypo only lasts like minutes. What are the counter-regulatory hormones?
There's 4. I'll leave that to the young fellas.
You've got a list too. There's 4. Yeah.
Cortisol.
Good.
Catecholamines.
Yeah.
Glucagon.
Yeah.
And growth hormone.
Great. Excellent. Very good. So those hormones, as soon as you get a low blood glucose, those hormones are going to kick in. And if you've had a well-managed diabetic, they're going to have plenty of glycogen stores in their liver and muscles to fall back on. So those counter-regulatory hormones are going to kick in, and that glycogen is going to get broken down, and it's going to not be a big problem at all. Whereas if you've been poorly managing them or loosely managing them, they're not going to have those stores to fall back on. And that's when you get the catastrophic hypos, is when they've been poorly managed and all of a sudden you hit them with a much higher dose of insulin, or if someone accidentally doses them twice or something like that. So it's only really massive insulin overdoses or poorly managed patients that can't cope with the hypo. So I tend to be quite aggressive with my insulin doses, and I think the CGM, the continuous glucose monitors, we see these curves come through and we go, oh, it's a little bit low. Let's drop the insulin a little bit because we want to feel safe. But if we look back on 3 years ago when we were doing a blood glucose curve, we never would have detected that hypo, and we probably would have upped the dose of insulin rather than dropped it. So I think there's a tendency to be a little bit more cautious with insulin with that extra information we're getting, and it's probably misguided. I haven't seen that written anywhere, but it makes good sense to me.
So if you're seeing brief hypos and you're otherwise looking good, don't be too likely to drop it.
No, exactly. Yeah. It depends a little bit on lifestyle as well. Like I always sort of check with clients how long the dog's on their own for during the day and stuff like that. Where, how aggressive I'm going to be. What are the other advantages to being aggressive about glycemic control?
In cats, you can get remission.
Good.
So being aggressive early and trying to obviously tackle any underlying trigger is important.
Do you know what the remission rate is with tight control, like they're running them at 3?
It's pretty high, I think. I don't know what the number is, but I think it's quite high, like most cats, I think.
Yeah, so 65% of cats will go into remission if they're very tightly controlled with insulin and what other modification?
Dietary,
exactly. So 65% of all cats. And then a lot of those cats have underlying conditions like pancreatitis, which are going to flare up. So 30% of those cats that go into remission will come out of remission, but I think that's pretty good odds.
Mm.
So there's a really good advertisement for being really aggressive with glycemic control in cats.
Can I ask a specific question about a specific cat?
Yes.
But I don't know the case, but I'm not managing the case long-term because this was an emergency presentation.
Mm-hmm.
But this cat, diabetic for more than a year, often wears a Libre sensor here and there to change the dose. So the owner said the dose changes quite frequently.
Mm-hmm.
And when the cat came in with a severe hypoglycemic episode this week at, I think, a 1.7 glucose, it hadn't been overdosed. It had received its normal morning dose of 7 units of glargine. And the owner just reported it seemed a little bit off the day before. Then she found it hiding. Then she brought it in almost comatose. But it had not received even its evening dose yet. It was like past, it all happened around the time that it would normally get its evening dose, but no one gave the evening dose. And I wasn't sure how the cat went from receiving that dose for weeks and being okay, which was it usually gets like 5, 6, or 7, and it was on 7. So having profound near-death experience.
Cats
recovered from, like, within 3 minutes, it was recovered.
Cats, again, don't follow the rules. So with cats, because we're dealing a lot with insulin resistance, and the conditions that cause that insulin resistance are fluctuant. So the degree of inflammation in this cat system is variable, and therefore its insulin requirement is going to be variable. So I would assume this cat had maybe chronic pancreatitis, for example, and that was one of the triggers of its diabetes. And potentially it was going through a good phase of its pancreatitis, and systemic inflammation decreased, insulin sensitivity increased, and the cat crashed. So those are cats that I like to have the CGMs on just constantly. 7 is a smackdown for a cat. It's a huge dose. So if I'm having to push it that high, and I'd be nervous and I'd have the CGM on, but I would suspect that that cat has been chronically hypoglycemic over a number of weeks to have run out of glycogen, essentially.
So it would have been having probably many Somogis before that final day.
Somoji is an interesting concept. So the newer sort of literature is suggestive that it doesn't happen, and that counter-regulatory response is a functional, helpful response, and that those, if you have sustained hypoglycemia, you're eventually going to run out of counter-regulatory hormones and glycogen. And particularly if that sustained hypoglycemia is to the point that it's impacting neurological function and decreasing food intake, because then just not going to be restocking those stores. But yeah, I can't see, unless that cat had a UTI that all of a sudden was treated or something like that, I can't see what else would have caused that. But yeah, CGM, a non-stop CGM would be my recommendation in that cat. But yes, they don't follow the rules. There's always one. So we talked about insulin in dogs, and that can insulin is typically our first choice. Is that everybody's first choice?
Yeah.
Yep. Why? What's the makeup of can insulin? What sort of insulin is it?
Porcine, I think, isn't it?
Oh gosh, I don't know. Lente insulin? Does that sound familiar?
It's intermediate acting lente, so
Good.
Like 25-30%, I can't remember, is quickly acting, and then 70-75% of it is a different makeup, complex, I don't know, particle size, I don't know, that is slower acting, so over the day.
Yeah, exactly. So if we think about the other types of insulin we've got act rapid or regular insulin, which acts over the course of what sort of time frame?
About 6 hours duration, but it acts within, 15 minutes, half an hour or something?
Yeah, exactly. So given IV acts for 2 to 4 hours, given IM up to 6, but 6 is stretching it, they're starting to escape then. So very short acting insulin. So like Helen said, can insulin is 30% short acting. And what that does is mimics that postprandial first phase. So where the duration of action was quite early. And then the rest is long acting. So 70% of it is long acting. So it's more similar to glargine or detamir in course of action. So it can be between 12 and 24 hours in some patients. And that just keeps the blood glucose flatter for the rest of the day. So the curve bit, the dip, is typically the regular insulin acting. So often you might see the curve. Sorry, I'm going backwards. I'm trying to go backwards. So you might see they eat, the blood glucose goes up, the regular insulin kicks in, the glucose goes down, and then they escape again. And it's probably because they need a bigger proportion of long acting. So if their blood glucose is only low or normal for a very short period of time, it's probably you've got too much regular and not enough long. Make sense? Mm-hmm. So then we talked about when we moved to cats, we talked about diet. Let's go back to dogs and say, what modifications are we going to make in dogs outside of dosing them with insulin? Consistency is a really, really important point that's not emphasized enough in all the literature. If you feed bickies in the morning, which are higher carbohydrate, the blood glucose is going to go boom, boom. And then if you feed tin food overnight or at night, then the curve is going to be completely different in the evening. So making sure that you're feeding the same thing morning and evening and every day so that you know that your insulin requirement is consistent. What components are we going to focus on in the food?
Oh, fiber is one thing.
Good.
But what's it called? Is it low or high glycemic index? I get confused.
Me too. We don't use it very often in the veterinary world, but
no,
it's a low glycemic index. Fiber, so oligosaccharides, which why would we want complex carbohydrates or soluble fiber in our diet?
Slower release of glucose, so you just don't get those spikes.
Great. Excellent. Yep. And there's something about oligosaccharides decrease digestion and absorption of carbs. So not only do they, so that's insoluble fiber, I think. Decreases absorption of glucose. What about fat content?
Low, I think.
Yeah, low. Because these are typically lipemic animals. So we don't want to add to the triglyceride load. What about protein?
Yeah, good quality.
Good, exactly. Yeah. So they've lost a lot of muscle because they've been eating it essentially. So we need to replace that. Okay, so what about exercise?
Yeah, well, that's important.
Consistency.
Yeah, consistency is, as Bron said.
I don't think we don't have a lot of data on the impact of exercise on glucose in dogs and cats because we've only just started using these continuous glucose monitors, but the impact is quite high. So what does exercise do to glucose utilization?
Well, the muscles use it, and they can. It's all they can use for energy.
Yeah.
But I look at it that there's three things you need to regulate or watch: the insulin level, the exercise level, and the food level.
Yeah, excellent. So if we're going to choose when to exercise our dogs in our curve, are we going to do it at the low point or are we going to do it at the high point?
At the high point.
High point, good. So exercise increases circulation. So we get better insulin absorption. We get a little burst of insulin absorption. We get better insulin delivery. And then we actually get increased numbers of those GLUT4 receptors or transporters in our muscle cells. So muscles have the opportunity to actually take more glucose out of circulation. So if you're doing that at the high point, you're going to flatten out your curve a little bit. Have anyone taken their cats for a walk? Diabetic management. It's so fun.
I wish I could. That'd be so cool.
My cat. Oh dear.
Cats are sprinters and dogs are long distance runners.
Yes, true. Yeah. My cat's not sprinting anywhere either, actually. Okay, so let's talk about insulin in cats. What's our go-to insulin?
Long-acting.
Good, excellent. So there's a consensus statement, which is handy because I always am nervous about making strong recommendations because nobody agrees on anything. But there's a consensus statement that was in JFMS, Journal of Feline Medicine Surgery, in 2015 that says glargine and says dose and it like spells out what we should be doing. Why do we use glargine as a first option?
They're more likely to go into remission when you're using it, but I'm not sure why.
Most likely to go into remission, but yeah, it just is. That's where the data is. There's doses in there. So it's like 1 unit for cats less than 4, 1.5 to 2 cats greater than 4 kilos, I think it was. And what are we going to do about diet in cats?
They can graze or just do their normal thing normally.
Yeah.
Low carbohydrate.
Yes, good. So the grazing is an important point. What's the duration of action of glargine?
14 hours.
16, yeah.
14 to 16, yeah. In some cats up to 24. It's a little bit variable. So what is our goal? If we're looking at a curve that comes out of a CGM in cats, what is our goal? Are we looking for a really nice like actual curve or are we trying to flatline it?
Just flatline it because they can get peakless curves when they're on it.
Yeah, good. So what Josh mentioned about cats grazing is a really good point because we do get little peaks after eating. And if you've got a cat on just long-acting insulin and they're really reliable in eating twice a day, then they might actually be better off on a combination of regular and long-acting because the glargine is sort of designed for cats who graze throughout the day. So just have a think about where those peaks are going to be and when the cat's active, like are they 2 a.m. cats or that might be sort of coming into your glucose management if you're seeing a weird curve.
And can I ask a quick question about diet?
Yeah.
Do you recommend and push the prescription diabetic diets, or do you feel like that's overwhelming for owners and you just say, okay, we'll just feed your cat something low carb and don't feed your dog toast to start with, or do you push?
In cats, I push diet pretty hard and I'll go a prescription diet in the absence of a better option at this stage. I think we need to do a lot of work on diets because when you look at the carbohydrate content, the prescription diets are still quite high. Just because the carbohydrate's kind of filler and it makes it cheaper. So many cats won't eat it as well. Does anybody find that?
Yeah.
Yeah.
Do you think that it's appropriate for cats to just be on like a balanced wet food that's low carb?
As long as you can get a low carb one.
Yeah.
And there's a few good ones out there. The important thing is not just low carb, but the type of carb. So some of the low carb ones that are sort of listed as low carb have the carb that's in there is quite simple.
Okay.
You're going to get this swing, which is not going to be appropriate with glargine. So I'm a little bit cautious, like low carb is great, but low complex carb is ideal. So I like the prescription ones because they're well researched in the types of carbs that are going in there. But I have to say, in cats that aren't fussy, I will say we're just going to do a whole meat diet for 2 months and unlikely to get any nutritional deficiencies over that course of time or significant ones, and give us the best chance of getting into remission.
Okay.
So pretty much 0 carb or like very, very low carb.
Okay.
That's nutritionists would go, but if we're just like really trying to intensively get them into remission, that's what I'm going to do. And then I'm going to try and maintain them longer term.
Okay, that's interesting. So literally just chicken, tuna, whatever they want. Meat. Yeah.
Great.
Great.
Make sure it's cooked. But yeah.
Yeah.
It's calcium deficient is the main nutrient that's deficient in just meat diet, because typically they'd be crunching on bones and stuff like that. So it's not, you can't do it long term. But if I'm just trying to get them into remission and I really want to change their diet acutely, I'm going to start them on that and get them to start like weaning onto diabetic food for long-term management down the track.
So there really is, I've never seen a cat go into remission and stay in remission. Like, they actually, so it's 30% or 65% will go into remission, and 30% of them will come out of it. So there is a decent proportion that should be able to stay in remission.
Yeah,
forever.
absolutely. Yeah, exactly. I don't, my stats aren't that high, but I'm not managing them as tightly as they were in that study. Anyway, and I just don't think, I mean, these are cats that were in a boarding facility being monitored and injected like as soon as their glucose spiked kind of thing. So it's not really, though I wouldn't expect to get those outcomes, but I would say this is our best chance. Do it early and do it hard.
And how are you monitoring for signs of remission? What's your kind of cutoff when you say, okay, let's stop with the insulin and see how we go?
So if I've got, because of the counter-regulatory hormones, we give insulin and then we get glucose like on a sensor going up to sort of 6 or 8 and down to 2.5-ish sort of thing. If we're flirting in that range, I'm going to start getting off insulin. Okay. And I'm not going to go, if we're getting in that range when we're on 2 units, I'm not going to go straight to off. I'm going to go to 1 and then I'm going to go to half. And then I'm going to say, let's just see what happens.
Okay.
Don't change anything. Yeah.
Once they're off insulin, do you keep a CGM on them and have the owner have a look at home off insulin rather than just look, wait for clinical signs or whatever? Yeah, absolutely. Okay.
Yeah. Cool. We've only got 1 minute left. So the main interesting point from a study that I want to share with all of you is the goal of treatment. We sort of talked about the different treatments that we'd use. But in a survey of a lot of owners, I can't remember how many, but it was a reasonable study of what their quality of life concerns were for the dog or cat. No, it was dog study. The top 10 quality of life reasons why they wouldn't pursue treatment were owner related, not dog related. So from an owner's perception of how serious a disease diabetes is, the dogs seem quite well and they're not too worried about them. It's more how this disease is going to impact them that is going to limit their wanting to go ahead with treatment. So as far as kind of, this is what we should do for the disease, sit down, what is your lifestyle? What is your schedule like? How would this impact you? Is this doable? Making it as sustainable as possible for them is going to mean you're doing better by your patient because they're more likely to pursue and persist with treatment. So I can't even think of 10 owner-related reasons, quality of life reasons, but they managed to come up with them. And the dogs seem fine, but they're like, I think we did pretty well.
We did very well as usual.
Definitely. It's a lot to tackle.
All right, we'll check out. I can't remember what next week is. I'll tell you next week.
Awesome. Thanks.
Thanks,
No worries.
Anna.
Have a good
Thank
day.
Anna.
Everyone.
Bye.
See you, Tony.
Bye.
Bye.